on time. But just to introduce myself, I'm Dr. Maas. I'm a physician at Reproductive Care Center. We're based in Sandy, Utah, as well as Clearfield, Utah. We're part of the Boston IVF network, as well as the EVRMA network. And I'm here to answer your questions. So as you're getting logged on, you're thinking about things, there is the Q&A at the bottom of your monitor. Go ahead and pop in some questions, and I'll do my best to answer them. Of course, anything today, please make sure you follow up with a physician to get your personalized answer and your personalized treatment plan. I'll give generalities, but I'm not going to be giving specific protocols or medical treatment recommendations for each individual. Today, we're going to talk about just an introduction to dealing with infertility. And also, I think recurrent pregnancy loss, people kind of lump this together. Separate entities, but both very, very impactful and very stressful. And actually, some of the research and data shows that people with a diagnosis of infertility suffer equal anxiety and depression as people with a diagnosis of cancer or HIV. So let that sit in for just a minute. If you think about your friends, your family members, if someone was diagnosed with cancer, you would be rallying around them. People are wearing their support ribbons, they're out there marching and doing races. But infertility is especially challenging because we have similar aspects of anxiety, depression, and stress, but much of this is faced at home without the support system, because there is a component where people, quote unquote, feel like their body has failed them or feel like they're broken. And so they don't always share their journey. I appreciate aspects like Facebook and Instagram and Twitter and getting the word out. But very often, fertility struggles are private struggles that people only share after they've gotten through treatment and achieved their family building. Similarly, multiple miscarriages, very stressful, very anxiety provoking, high levels of depression. And oftentimes people don't share their story until they're well into their journey or their treatment. So as you're looking at doing self-care, think mindfully about who you want to have in your support groups, whether it's friends, whether it's family members. Understand that friends and family members are generally well-intentioned, but often can say hurtful things without meaning to do so. And having a plan about how you're going to approach some of these situations. If you're going to a holiday and you know someone's going to ask you when your family building is going to start, think about a response in advance, or think about pulling family members or friends aside to ask them not to do that in a group setting. So having a plan. If you have a partner, having a safe word or an exit word, like, hey, let's go get some milk, is I can't deal with this situation. Let's get out of the room. I need to take time to take care of myself. There's other support networks in Utah. We have Utah Infertility Resource Center. Depending on where you are, Resolve is an amazing resource for people struggling in their family building journey. And then there's lots of community groups, Facebook groups, social media groups. Search online and find your group to help you support yourself. And then this is also a time to be selfish. If you're getting invitations to baby showers, reach out, politely decline if that's too much. Communicate what your needs are with those around you and make sure that you're putting yourself first. This also means taking good care of your physical health in addition to your mental health. And for people that are dealing with stress or anxiety or depression, oftentimes there's an association with disordered eating. That can be eating in excess. That can be restrictive eating. We're trying to control an aspect of our life that we feel otherwise just generally out of control of things. make sure that you're nourishing yourself. You're eating a well-balanced diet. You are actually eating. And then physical activity is so important for physical health and mental health. There's data that says that exercise can act as well as an antidepressant in a significant portion of the population. So trying to get out, it doesn't have to be running a marathon. If that's your thing, that's fine. But it doesn't have to be running a marathon. It could be going for a walk around the block and doing so alone if you want some alone time, or doing so with your partner to be able to communicate. It's a very nice time where you're unplugged from the rest of the world. You're not looking at your phone. You're not looking at the TV or the computer. You can really focus and communicate with each other. So all in all, most important thing, take care of yourself, communicate your needs, and take care of each other. I'm going to pop over to a little bit of the Q&A questions. So one of the ones that we get frequently is, does stress impact your chances of achieving pregnancy with treatment? And the data on that is actually quite muddy. There's some studies that suggest that reduction of stress can be beneficial and help you achieve pregnancy. There are other studies that show that it actually doesn't impact outcomes. I generally think of it as not being a make or break factor. You're not stressing yourself into infertility. You're not stressing yourself into a miscarriage. But general health and well-being is reproductive health. So you want to try to minimize your unhealthy aspects of your life in general. So try to reduce stress, but try to not stress about being stressed. Now, when we get to severe stress, let's say you've lost so much weight, you're not having periods anymore. Now, that type of stress, yes, that can definitely impact reproduction because your body is shutting down. It's going into survival mode. But this is severe levels of stress. If you were alone in a jungle without food, yes, that's going to shut down reproduction. But we can't quantify kind of day-to-day stress and associate that directly. One of the other questions is, how can you quantify stress? And the world is generally stressed, and we're all stressed. I wholeheartedly agree with that statement. Stress is hard to quantify. There's a bunch of subjective questionnaires that you can take. Mental health providers have these. They can be helpful. The caveat being they're going to vary from day to day, right? Our stress varies from day to day or moment to moment. Just thinking about, popping online, or for many people, going to see the doctor for the first time is stressful. But it's hard to quantify that, and it's stressful to different degrees to different humans. And unfortunately, there's not a good stress metric or calendar or scale, but there are questionnaires that you can use to get a better idea. And these can be done through primary care docs, mental health providers, or counselors. And I would strongly encourage anybody going through their family building journey or their miscarriage journey to engage with these resources. How do you reduce stress during this process is one of the questions. And I think really doing self-care and communicating your needs, again, would be my recommendations. Exercise is important. Some people need medications. And yes, if you don't need medications, please don't take medications. We're trying to minimize exposures in pregnancy, but some people need antidepressants or anti-anxiety medications to be functional, to feel like themselves, to be able to function in a day-to-day world. And so that's not a failure, that's a support to get you through. And there are medications that are safe to try to use when you're trying to conceive or having miscarriages. There are clearly medications that you should not be on if you're trying to conceive, and you would want to communicate that with both a mental health provider as well as your reproductive endocrinologist to make sure that everybody's on the same page. One of these, how to prepare for an upcoming IVF cycle. So IVF definitely is an investment. You're investing your time, finances, your physical self, and your emotions in this. And I think having a communication with your doctor about expected outcomes so that you can have a anticipation of how things may or may not go. Do they expect that you're going to need multiple treatments? Statistically, is this likely enough to get you to your goal? So communicating with your doctor to set realistic expectations. Communicating with your support system if you feel comfortable that you're going through treatment, that you may need to take time off for appointments, that you may not feel like yourself as you're going through treatment. It's emotionally and physically taxing. You're going to be off for a day out of kind of day-to-day life for the day of your egg extraction. And so I think communicating with your network and your support team, and then also engaging in some of those community resources like Resolve, like Utah Infertility Resource Center, or the infertility community within your geographic area. And then timeline for IVF kind of goes along with this. You're going to be communicating that you're going to be going through the stimulation phase to get eggs for about 2 weeks. And then some individuals have what we call a fresh embryo transfer. And that is generally 5 days after an egg extraction. So it's about a 3-week duration there. If you're doing genetic testing of embryos or doing a frozen embryo transfer, it's generally a month to create the embryos and then another month to prepare for the embryo being transferred. And so that's a 2-month process. So I think setting expectations with your group and your community about kind of where you are, you're like, hey, you know, for the next month, I may not show up to a baby shower. For the next 6 months is going to be helpful to help you kind of plan your life, alleviate stress, and maintain that support system for yourself, as well as still feel engaged with your community. Let's see. Someone asking about exercise and what exercise is safe to do during fertility treatment. So exercise is great. It's good for your mental health. It's good for your physical health. Now, during the IVF stimulation process, your ovaries do get large, and your ovaries actually are held in place by ligaments and blood vessels. And so during the IVF process where you're stimulating to get eggs for an egg extraction, you don't want to bounce the ovaries too much or jostle them because they theoretically could twist on their blood supply. Very uncommon, unlikely, but we don't want to tempt fate and have them twist. So no high impact or bouncing activity during the IVF egg extraction process. Now, during a transfer, you're fine to go back to day-to-day life activity. I usually say this is a time to maintain your current activity or gradually increase your activity. It's not the time to do a couch to a marathon. I do have people that are marathon runners. They are able to maintain their current level of activity, but you're usually titrating your pace and your distance to where you're feeling good. As you get further into pregnancy, people may not feel as comfortable. The weight of the pregnant uterus, the weight on the joints, you get more stretchy. That's the nice thing about pregnancy, is it makes your joints and ligaments a little more flexible, which is good, but then also you have to support them a little bit more with your muscles. So you just need to be mindful of your current level of fitness. And this isn't the time to ramp things up crazy, but gradual, slow increments. If you're feeling really short of breath, if you're feeling really sore or achy, then you need to just turn that back down. It's always good to consult with your doc about where your treatment is and then help you kind of gauge your timeline for your intensity of your activity. Here's another question. 36 years old, been trying to conceive for 9 months, and should I see a fertility doctor? And I would say yes. So at age 35 and above, infertility is 6 months of trying without success. Under age 35, it's a year. 80% of pregnancies are achieved within the first 6 months of trying. So that's where we start assessing the sperm, the eggs, the tubes, the uterus, to see what parts and pieces you're working with and what you may need assistance to help you achieve pregnancy. Additionally, 20 to 25% of patients will have what we call unexplained infertility. Now, unexplained infertility means, hey, we've got all the parts and pieces, but we're still not getting pregnant. And that doesn't mean just keep trying. That's tough. Sometimes people are like, oh, just keep trying, or just don't stress as much. What you do need in unexplained infertility is more sperm, more eggs, more chances to get to the right combination of sperm and egg. And so that does require treatment, but treatment of both the sperm source and the egg source. I'm just reading a little bit more. A 36-year-old daughter and would love to carry a baby, 49 years old, still having a period. What is the level of risk to cancer after a procedure? And so I do have individuals that are carrying pregnancies at more advanced reproductive ages. I have people that are postmenopausal who are going through fertility treatment and carrying a pregnancy. Generally, that's with either a donated egg or a donated embryo. The difference between an egg and an embryo is sperm and egg that have come together and grown in a petri dish. And so it's further along reproductively than an egg. A donor egg you place with sperm, and it could be from donor sperm or partner sperm or intended parent sperm, and then you grow it into the embryo. And using donor egg or donor embryo, you could get pregnant even if you don't have a period. And that's because I can take over hormonally for what the ovaries normally do and give hormones to support the uterus to carry a pregnancy. Now, things that we do test, if you're over age 45, we want to make sure that you've had a colonoscopy. That's making sure that's up to date. We do cardiac testing. That's things like an echo, an EKG. We do kidney function testing via urine tests and blood tests. Over age 40, we make sure that everybody has their annual mammogram, and that's up to date. And then anybody going through fertility treatment should have a pap smear, ensure that's up to date. So we're doing routine cancer screening before you achieve pregnancy. And now fertility treatment itself does not increase your risk of cancer. Hormones that go up with pregnancy can exacerbate an existing cancer. So breast cancers, for example, can be hormonally responsive. There's some that in the presence of estrogen or progesterone will grow. Pregnancy is the highest hormonal state your body will ever experience. So that's why we do baseline cancer screening before achieving the pregnancy. So if there's something that we're concerned about, we're screening for that and treating it if needed first. Hopefully that answers your question. Next question, what are FSH and AMH levels? FSH stands for follicle stimulating hormone. AMH stands for anti-Mullerian hormone. And these are hormones in your blood that we can test to get an idea about what we call ovarian reserve or egg supply. Individuals with eggs are born with every egg that they will ever have. And the quality and quantity of eggs both decline with time. We don't have a test for quality. The best estimate is based on age. But we do have tests for relative quantity, meaning do you have a lot of eggs, a medium amount, or a small amount? FSH is the hormone that comes from the brain. There's a little gland called the pituitary gland. If you put your tongue all the way to the back roof of your mouth, there's a little gland about the size of the tip of your pinky on the other side of that bone, and it releases FSH, which by name, follicle stimulating hormone, stimulates the follicles on your ovaries. And this is actually the hormone that IVF medications mimic. It's a pharmacologic mimic of this, just in a higher dose over a longer duration to try and grow more eggs. AMH is released from the ovaries. It's part of the way that the potential egg of the month is selected. As all the eggs are fighting it out, trying to figure out which one is the egg of the month, they're releasing and communicating with AMH. So the more eggs you have, the more AMH you have. The fewer eggs you have, the more your pituitary gland has to yell at your ovary to do its job. And so the fewer the eggs you have, the higher your FSH level is. FSH should always be checked at the same time as another hormone called estradiol, which comes from the ovary. These work in what we call a negative feedback situation. So if estrogen's low, FSH is high. And similarly, once the egg starts to grow, estrogen rises, and that suppresses FSH. So an isolated FSH without an estradiol level is not particularly helpful. But these are both blood tests that we can use to try and assess how you'll respond to fertility treatment and what may be a good option for you. Next question, with IVF, can I choose the sex of the baby? And the answer is yes and no. It's both at the same time. So IVF, unfortunately, doesn't allow us to select an X sperm or a Y sperm to create an embryo, but we can create embryos. And then we remove cells from the area that becomes the placenta. That's called PGT. And that's where we take a little biopsy using a laser. And we send those cells off, and they will tell us whether or not they're XX, which is chromosomally female, or XY, which is chromosomally male. With that, if you have embryos of both, you could choose which one was transferred into your uterus, and you could choose to know, you can choose to not know. But unfortunately, I can't make an embryo of a specific gender. I can only test to figure out what it is and choose whether or not to transfer it or. Next question, how does age factor in if you've already had eggs frozen but are now older and ready to use them? So when we do fertility preservation, whether it's freezing eggs or freezing embryos, those are now frozen in time, and they have the reproductive potential of your age when they were frozen, even if you're using them years later. Our uterus thankfully ages slower than our ovaries. So we can use our uterus, as I mentioned, even after menopause to carry a pregnancy. Whereas we generally run out of eggs at the age of menopause, but the functionality of them generally is limited even 8 to 10 years before menopause. And the average age of menopause is 50 and a half. So that's why fertility and human reproduction becomes more challenging in our late 30s, early 40s versus in our 20s and early 30s. Can stress impact implantation or pregnancy in the first trimester? And this circles back to the fact that there's not really solid data, and it goes back to the other question of how do you measure stress? Everybody is stressed going through fertility treatment. It is undeniably a stressful situation. The good news is if stress was the make or break factor, we'd have 0% pregnancies in our fertility treatment. And thankfully we do get pregnancies, but some data says stress can reduce pregnancy rates. Other data says it can't. Try not to stress about being stressed. It's not the make or break factor. It's something in general, we want you to lower your stress for your general health and well-being, but it is not the thing that's keeping you from becoming pregnant, nor is it the thing that would be causing a miscarriage. Let's see. 2 failed IUIs. Trying to figure out whose eggs to best use when someone is 34 and someone is 38. So age is the strongest determining factor for egg quality. At age 34, the quality of the eggs, meaning the percent of eggs that are genetically normal, is going to be higher than the percent of eggs that are genetically normal at 38. So around 38, maybe 60 to 70% of the eggs may be abnormal, whereas at 34, maybe 40 to 50%. That said, everybody's quantity changes at different rates. So you may want to assess quantity of eggs. If someone's 38 and has a ton of eggs versus someone that's 34 and has very few, that may change your planning for your family building. So you want to assess quantity. Again, that's with the AMH hormone we talked about. FSH gives some data, but it's an older test. And then there's also an ultrasound called an antral follicle count. That's where we look at the ovaries. We see how many small little circles on them, and that gives me a rough estimate of how many eggs I may be able to get with fertility treatment. And that can help elucidate who may be the best person to go through the IVF process. Just based on age alone, 35 would be preferable to 38, but again, it's more than age as a determining factor. Let's see. What happens during the initial fertility assessment and testing? So when someone comes to my office, we talk about, first and foremost, family building goals. How many children are you hoping to have? What does your family look like in a perfect world? Because that helps me guide my recommendations for treatment. If you're 42 and you want 5 children, then my plan's very different than if you're 22 and want 1 child. So we've got to really personalize your treatment plan for what you're looking at. In general, I'm looking at sperm. With a semen analysis, we want to look at this 2 to 4 days since the prior ejaculation. After 5 days, the quality of sperm starts to fall off. It's built up at the front of the reproductive tract, and then dead sperm don't swim very well. They also start to disintegrate, so their shape is abnormal. And sperm does fluctuate from day to day. There'll be good days, there'll be bad days. So we do, if things are abnormal, want a second data point to understand where we're fluctuating. Additionally, some of the more recent data suggests that about 20% of individuals that have a normal first semen analysis will have some abnormality on the second one. So there are some physicians that recommend 2 semen analyses for everybody. The other components that we look at are the anatomy. So that's either the hysterosalpingogram, which is an X-ray that looks at the uterus and the fallopian tubes to make sure that the fallopian tubes are on each side. Gives me a rough 2-dimensional view of the uterus. And then the other anatomic look is an ultrasound, and that's generally done with saline insertion into the uterus so that we can do a 3-dimensional reconstruction of the inside and see if there's anything abnormal inside the uterus. The ultrasound also allows us to do that antral follicle count, which is an ultrasound of the ovaries on each side to get an assessment of egg supply. And we're combining that with egg supply hormone testing, generally AMH. Occasionally we'll do FSH, or what's called an ovarian assessment report, which includes a whole multitude of hormones. And then we also do routine prenatal labs. It's important to make sure that we're healthy and safe for pregnancy. As I mentioned, for people that are more advanced in their reproductive age, we're even doing things like colonoscopy, making sure mammograms are up to date. For anybody planning pregnancy, even if you're in your 20s, we're doing a blood count, blood type, vaccination status. We're looking at infectious disease screening. We're looking at recessive gene mutations, which everybody carries. And you don't know what you carry unless you do blood testing. And that's routine recommended pre-pregnancy screening for anybody planning pregnancy. It doesn't have anything to do with miscarriages or infertility. And that's because, again, everybody carries gene mutations. Other tests may be personalized to your specific situation. So we do other tests for multiple miscarriages, but globally, we're trying to figure out what we're working with so that we can target treatment to the right aspect. If you're looking at using donor egg or donor sperm, that genetic screening, we need to cross-reference with the egg source and the sperm source. Donor sperm patients would be also screened for something called CMV immunity. CMV stands for cytomegalovirus. This is a mild virus that if you get it as an adult, not a big deal, may cause some mild symptoms. If you get it while you're pregnant, it could cause severe abnormalities in the pregnancy. So if someone is not immune to CMV, we would recommend using a sperm source that is CMV negative if it's donor sperm. Interestingly, we actually don't screen this if it's a sexually intimate couple, because theoretically there's exposure in their relationship already. Let's see. Someone exercises regularly. Do they need to modify this during a natural treatment cycle if they've already created embryos? They're struggling with thin lining, but not sure if this has an association or not. So in general, during a natural cycle or a low technology cycle like Clomid or letrozole cycles, normal activity is okay. Now, thin lining is a tricky situation, and there's multiple potential causes. Sometimes it's low estrogen. Sometimes the egg is out of sync with the uterus, and we need to kind of resynchronize. Rarely there can be things like scar tissue inside of the uterus that is keeping the lining from thickening. But I would talk with your doctor about what their concerns are. Oftentimes, I'm adjusting a protocol or making a different plan, especially if I'm continuously canceling a cycle for a thin lining. Usually, I'm trying to assess and make sure there's nothing else that I'm missing that may be contributing. Now, let's say your BMI is really low, you're really lean. That could be something where you have low estrogen throughout your whole body, because estrogen is produced from fat or adipose tissue. And so that estrogen may need to be supplemented or supported a little bit. Any chance you can conceive naturally if you've had IVF previously, or do you need to go for IVF again? And statistically speaking, people that have infertility have infertility. That said, some people do conceive spontaneously after going through fertility treatment. The caveat is we don't have a good predictive factor. Now, clearly the cause of the infertility is important. So if sperm was really, really low and nothing's changed, then it's unlikely that you're going to conceive spontaneously if sperm was really low. Additionally, if both fallopian tubes were blocked, then you're not going to surpass that just by carrying a pregnancy. But if we're unexplained, or if it's something mild like ovulation dysfunction that has improved, then it is possible to conceive spontaneously. That said, I wouldn't encourage someone to kind of languish as trying on their own for years. If you're not pregnant within 3 to 6 months, probably time to re-engage with a fertility practice and try and get repeat updated testing and treatment planning. As far as, I'm going to skip down to a short one that's a little easier to read. Would I recommend IUI for someone that's 39? For age 39, you're in this category. There's this nice study, if anybody wants to look it up, and it was actually from Boston IVF. It was called the 40 trial, FORT-T. And they looked at individuals that were 38 to 42 with unexplained infertility. And they sent a group through 3 medicated IUIs, and then if they weren't successful, through IVF, and then another group through just directly to IVF. And in unexplained infertility in the 38 to 42-year-olds, starting with IVF first was superior, faster time to pregnancy, and generally lower cost because most of the individuals eventually needed IVF. Now, IVF is not a one-size-fits-all. So as I mentioned previously, egg supply is an important part of our testing. If someone is cycling regularly, meaning you're having a period every single month, then foreseeably you are ovulating 1 egg per month. If I've done your egg supply testing and your testing is really low, let's say your AMH is 0.05, or your antral follicle count ultrasound shows 1, maybe 2 follicles, then you're not a great candidate for IVF, because where IVF is beneficial is that it helps us get more eggs than we would safely get with something like IUI. And we're able to put the sperm and egg together in a petri dish and grow them to be able to filter down to the one that's most likely to achieve pregnancy. It's also helpful if sperm is really sluggish in swimming or low in number, and I have to put sperm and egg directly together, or if the tubes are both blocked. But if you can only ovulate 1 egg a month, sperm looks good, tubes look good, uterus looks good, and if I'm doing IVF and I'm only going to get 1 egg and everything else is normal, IVF isn't a great option in that situation because it's not doing more than what nature would be doing. Let's see. Someone asking about infertility experiences on social media, which is increasing their levels of stress and starting to worry about their journey, about failed treatment or lack of success, and how to avoid doing this. And this is very common. We know that social media actually is a challenge. It's great because it has things like this where you can get information, but it's also nuanced in the fact that everybody provides kind of a personal perspective or a personal narrative on their social media. And so with social media, some people share their journey and highlight failures. Other people share their journey and highlight successes. And so if you're stressing about this, I would encourage you to pull back a little bit from kind of personal accounts, stick with more infertility specific educational resources, go to your fertility doctors, go to Resolve, and then also try and go to online websites rather than social media for your information. The American Society for Reproductive Medicine, or ASRM, has some really wonderful patient information guides. So I would encourage you to look at that. And then there's some great resources, fertility books and mental health books by PhDs. Dr. Ali Domar is an excellent one, but there's many physicians and PhDs in the field that can speak about the fertility process and the stress of it. So I would encourage you to focus on yourself and your journey because everybody's journey is different. I think there is some benefit to understanding that IVF is not always successful. It's not a guarantee, that it may take more than 1 treatment cycle. But then there's also stress and frustrations that other people are getting pregnant when you haven't. So it's nuanced. I would say try and narrow your time down. Like, I'm going to spend 30 minutes, 3 days a week looking through this, and set a timer. Give yourself a limit. Try not to just let it take over your life. Next questions. How does IVF work when you're on hormone replacement therapy for premature ovarian insufficiency using donor eggs? So one important thing about this is with ovarian insufficiency, that means that we've run out of eggs or have very low egg number. That's where I was talking about that AMH level being very, very low. And so going through self-treatment, getting eggs from your own ovaries can be of limited utility. And so as this person mentioned, they're using frozen donated eggs. And this is similar to our treatment that we use when people are in menopause, where we're giving you medications that act like your ovaries. That's generally estrogen pills to thicken the lining of the uterus, and then progesterone, whether it's a daily vaginal suppository in combination with injections, or injections to support the pregnancy. And usually most doctors will do this through 10 weeks of pregnancy. The placental tissue takes over before that. We overkill this by about 2 to 3 weeks, but we support that. And then the placental tissue takes over and supports the pregnancy through the rest of the pregnancy into the second and third trimester. So medications and hormones, it's essentially a fully medicated embryo transfer. Hopefully that answered your questions. Can PGT-A, PGT-M, and PGT-SR all be done before implantation? What if a miscarriage still happens after these testing techniques are done, or if a fetus has chromosomal abnormalities? So PGT stands for pre-implantation genetic testing. This is where we're removing several cells from the area of the embryo that becomes the placenta. We haven't figured out how to biopsy baby and have babies, so we biopsy the placental cells. And PGT-A looks for aneuploidy. This looks for extra whole chromosomes or missing chromosomes. And this is the most common cause of an embryo not sticking, as well as aneuploidy being the highest rate of causing miscarriages. PGT-M is looking at single gene mutations. Examples would be things like cystic fibrosis or spinal muscular atrophy. Most people doing PGT-M also do PGT-A. If you're doing PGT-A, I have to know what I'm testing for PGT-M, which is why we do that recessive carrier screening that I had mentioned previously, as that tells me whether or not I need to do PGT-M. And then PGT-SR is generally looking for, it stands for structural rearrangement. We're very often looking for translocation. A translocation is where part of one chromosome is broken off and kind of stuck to another one. And we have to make sure that we're looking at the right portion of the genetics. We don't look at every single gene, every single aspect of each chromosome. We get a global view or a very, very zoomed in view if we're doing PGT-M. So if we're doing PGT-SR, I have to know where to look. And these are done by biopsying the area that becomes the placenta and then freezing the embryo, and then we send these cells off for assessment. So it's done before an embryo transfer. Now, they don't guarantee a pregnancy, nor do they remove the risk of miscarriage. They definitely reduce the risk of loss from genetic abnormality, but cannot eliminate it. And they also can't look at every potential thing. There's things that are spontaneous mutations or non-genetic problems that can arise. So it doesn't guarantee live birth or a healthy child, unfortunately. We're just not there yet. We're getting closer, but I still think that there's more time to develop new tests over the next 10, 20 years to get us there. Let's see. Can I explain why a thyroid level needs to be optimal for implantation? So thyroid, I think of as the temperature setting for baking your bun in your oven. You want it to be at the right temperature, not too hot, not too cold. And so the thyroid is the important temperature setting. When we get pregnant, our thyroid requirements go up by about a third. And so our thyroid has to work harder and gets more stressed. And so we want to optimize your thyroid before you achieve pregnancy and then monitor it closely during pregnancy. So when you're on thyroid medication and achieve pregnancy, anticipate that your dose of medications is going to be adjusted. It'll likely be adjusted after delivery and then may be readjusted back to your baseline in the postpartum period. The guidelines are more, the threshold is 2.5 or lower for people that have autoimmune antibodies. That's things like thyroglobulin antibodies, thyroid peroxidase antibodies, or thyroid stimulating antibodies, also known as Hashimoto's, because these individuals are a little more fragile and can swing out of control more readily when achieving pregnancy. Is there something that can be done to help a fertilized egg stick better to the uterus? Now, placing an embryo, which is a fertilized egg, into the uterus needs to be synchronized with the lining of the uterus. So the lining of the uterus needs to be ready for the embryo to potentially stick an implant. There's things marketed like embryo glue or scratch biopsies that people have theorized. Now, these have not actually been shown to improve implantation rates. And in general, we think that the reproductive potential of an embryo is very similarly linked to the embryo itself and your chances of achieving pregnancy. Clearly, there are environmental components. We need to make sure that the anatomy of the uterus is healthy and normal. You don't have polyps or fibroids or scar tissue or anything that would potentially be impairing implantation. We need to make sure that your hormonal environment is normal. You're not severely diabetic with really out of control hemoglobin A1C or prolactin that's elevated or thyroid that's out of control, and that your general health and well-being is optimized. But sadly, we don't have like super glue or staples or anything to make it stick and stay stuck. How to prevent chemical pregnancies after the transfer, I think, kind of ties into that. Most chemical pregnancies we think of as being related to the embryo itself. The good news is the embryo is sticking, so the uterus is being receptive, but it is mostly thought to be associated with that particular embryo. Unfortunately, fruit juices like palm and pineapple and things like that are not going to improve implantation nor the success of implantation being maintained a healthy live birth. We do test the hormonal environment, the autoimmune environment, the anatomy to make sure it's optimized if we have recurrent biochemical pregnancies. But I wish pineapple juice was the cure. If it was that easy to cure infertility and in biochemical, that would be amazing. I would love for patients to be able to drink pineapple juice. Let's see. Flipping through. Can you have a successful pregnancy after having an ectopic pregnancy? Yes, you can have a successful pregnancy. An ectopic pregnancy is considered any pregnancy that sticks outside of the uterus. That's ectopic. And this makes you concerned that there's some abnormality or a rough spot that embryo found and thought was favorable to stick. So if we have an ectopic, that does concern me that there may be some abnormality to the fallopian tube. It increases the risk of subsequent ectopic pregnancies. And I would want to make sure that the fallopian tubes were tested to make sure that they're both open. Sometimes with ectopic pregnancies, we have to actually remove a fallopian tube to treat it. You can get pregnant with only one fallopian tube. It doesn't take two tubes to achieve pregnancy, and it doesn't even take the egg and the tube on the same side. About a third of the time, a left tube will pick up a right egg or vice versa. Oftentimes patients will ask me if we need to cancel a cycle because they're ovulating on one side, but that tube's blocked. Hey, ideally, perfectly, I would love for a tube to be open on the side that we're ovulating the egg, but even if not, the other tube can pick it up. So I do recommend that people go through with their treatment if that's the case. Someone that had a miscarriage, 2 miscarriages after a pregnancy, and then had what's called a hysteroscopy. That is where we place a camera through the cervix into the uterus and look around, treat anything that would be abnormal or not. And then they had chromosome testing for themselves and their partner, which came back normal, and they're going to start IVF. And the question is, does it usually take several rounds for people with secondary infertility, meaning they achieved pregnancy before, but haven't achieved pregnancy that was an ongoing pregnancy the next time around? And the success rate of IVF is very strongly tied to egg age, but also egg quantity. So if I have someone that's 37 and I'm getting 2 eggs versus someone that's 37 and they can go through IVF and get 22 eggs, if you're going to get 22 eggs, then you're much more likely to get to live birth from a single cycle than someone who's getting 2 eggs to get to live birth from a single cycle. So there are some statistical models that can be used, and your doctor should be able to share those with you and review what your personal probability is and help provide guidance. Reproductive Care Center is great in the fact that we do offer multiple cycle packages, and very often when I'm speaking with my patients, I'm trying to provide some rough expectations so they can think about what package may or may not be right for them. And especially if they're thinking about family building, we try to estimate, if people want 2-3 more kids, what we should try to have in the freezer to achieve their ultimate family goal, which is why that's one of the very first questions I ask my patients. And one of the things that you should definitely discuss with your doctor, your healthcare provider, is what your family goals are. If you're 40 and you want 3 more children, well, we may need to think about not only infertility treatment, but fertility preservation, depending on where you are in your timeline of things. And you don't want to get pregnant and great, you're pregnant, but that puts any type of fertility preservation on hold until you've completed that pregnancy. So you should have a global discussion about goals and family building timeline so that you're doing the treatment that's the right treatment to get you to your family. Let's see. A little more about PGT-A. That's the pre-implantation genetic testing for chromosomal abnormalities. And is there anything that we can do to improve it? And sadly, the most predictive factor for this is egg age. And that's because the quantity and quality of eggs is very strongly tied to age and declines with time. There's some suggestion that you could add kind of some supplements, but I've had people try supplements and what we call adjuvants, where you're adding things, and some individuals do better, some individuals do exactly the same, some theoretically can do worse. And I think that's just month-to-month variability. So I'm talking with a age, we're talking percent of eggs that are abnormal, but that's globally through all of the eggs that are left. So you may go through a cycle and have no eggs that are normal that cycle, and then the next cycle have 2 or 3 that are normal. And so with each month is a new group of eggs with a new reproductive potential. If we're talking about 39 with 5 of 7 blastocysts, that's within kind of an expected trajectory. I would say a range of 0 to 3 would be expected to be genetically normal out of 7 at age 39. So having 2 of 7 normal, 5 of 7 abnormal is within an expected range. That said, again, general health and well-being is reproductive health. So optimize your general health. Things like toxins such as tobacco can prematurely damage and deplete the egg supply and egg quality. So please avoid exposure to toxins. How much gap should someone keep between 2 transfers for their best outcomes? So you can go from transfer to transfer month to month as long as the ovaries are resting, the uterus has resolved. Once you've delivered a child, what we call interpregnancy interval, which is time from delivery of one pregnancy to the initiation of the next pregnancy, to reduce the risk for the person carrying the pregnancy, as well as the fetus, is ideally 18 to 24 months. There are times that we shorten that, especially if we're further along in our reproductive timeline. And we discuss that with the patient and the healthcare provider to balance the risks. Clearly, if someone went into labor at 25 weeks, I'm not going to want to shorten that to 6 months. If someone had a healthy, uncomplicated vaginal delivery, then I may shorten that timeline. But it's counseling and shared decision-making about how to optimally time inter-pregnancy interval. But you don't need to take time off if you've had an unsuccessful transfer. If you've had a miscarriage, then you do at least need to get the pregnancy hormone back out of the system. So pregnancy hormone needs to go to negative. Let's see. Is there any test with multiple failed transfers to stick or implant? And we are still trying to fine-tune a diagnosis of what is recurrent implantation failure in our field. And it's hard because not every embryo is considered the same. So those that are genetically tested have a higher chance of sticking than those that are not genetically tested. An embryo from a 25-year-old that's not genetically tested has a higher chance of sticking than an embryo from a 42-year-old that's not genetically tested. If we think about it, we do very similar testing to what we do for recurrent pregnancy loss. We're looking at the environment. So that's some sort of anatomy assessment with either a hysterosalpingogram, also called an HSG, and a saline sonohistogram, also called an SSG or an SIS. We're testing the environment. We're looking at the hormones. That's things like your thyroid, prolactin. We're looking at hemoglobin A1C to see if you're diabetic or pre-diabetic. We often look at autoimmune factors. There's antibodies called antiphospholipid antibodies. There's 3 of them. There's lupus anticoagulant, anti-beta-2 glycoprotein, and anti-cardiolipin antibodies. And those are all blood tests. Technically, if they're positive, they need to be positive on 2 separate episodes, 12 weeks apart, to have a formal diagnosis. And then oftentimes we're looking at karyotype for the egg source and the sperm source. Karyotype is looking to see that there's 2 sets of chromosomes, that nothing's broken off or glued onto another. Then we're also considering genetic testing of embryos to sort out the ones that are abnormal and are unlikely to stick, or if they do stick, very likely to be a miscarriage. Let's see. Is it a good idea to take a break from treatment if you're stressed about the process? And I would say yes. In general, I've never had a patient regret taking a break from treatment. But I think the duration is something that you should speak with your doctor about. So if you're older with lower egg supply, yes, take a break, but please don't take a break for a year. Take a break until you kind of get your feet underneath you. If you're young, yeah, you have more time, more bandwidth to work with. So talk to your doctor and your team about the timeline so that we don't get into a situation where you take a break so long that we've now limited some of our treatment options. But absolutely take care of yourself first. I definitely advocate for people taking a break if it's become too much and just get their feet back underneath themselves, approach treatment with a better state of mind and better support going into it. Let's see. Having a successful pregnancy from a frozen embryo transfer at age 37 and trying again at 40, doing a transfer from the same group of eggs, is the age difference a factor in a recent lack of success? And this circles back to the fact that age is fixed in time when you freeze an embryo. 37 to 40 is very minuscule difference in the health of the uterus. If anything, I think of this just being a difference in embryo quality related to that specific embryo. So not every embryo is going to stick. And I think that for people that have success with their very first embryo transfer and they have a live birth, it's hard to understand going through fertility treatment and not having it work, which is super frustrating. It's like, hey, last time, whenever I transferred an embryo, it worked. But at best, even if we've genetically tested the embryo, it's about a 60% chance of sticking. So if one of them doesn't stick, I don't panic. I'm just like, okay, that's probably not the right embryo. We need to just get another one, get into the uterus and give it a chance. Okay. Patient with PCOS after IVF having regular periods. Does that mean you're ovulating? How reliable are ovulation tests? And I would say on average, if you are cycling regularly and predictably every 28 to 30 days, then yes, most likely you are ovulating. Now, if you're someone that you cycle 25 days, sometimes 37 days, sometimes 32 days, that makes me a little more concerned that you are not reliably ovulating. And so regular should be within a couple of days plus or minus. We can check to see if you're ovulating by several different things. There's ovulation predictor kits. Those are urine tests that you pee on, and it tells you if you're about to ovulate the next day or not. Those can have false positive or false negative rates up to 10% of the time. So they're not perfect, but they are very good. And then another hormone level called progesterone, which is the hormone that goes up after ovulation, can also help determine if you ovulated or not. So there's multiple ways of looking at ovulation. And I would encourage you, if you think that you are cycling regularly, to maybe reach out to your OBGYN or your infertility doctor and have them do that progesterone level check to confirm or refute what I'm suspecting. Okay. Next question. What follicle size are you looking at for an IUI? Is it possible that some women do not make larger follicles? Is this a sign of infertility? Generally, I'm looking for a follicle in the 16 to 25 range. Follicles that are 14 millimeters and above usually have the receptors to respond to an ovulation signal or ovulation surge, whether that's from your own brain, that LH surge that we pick up on the ovulation predictor kit, or from a trigger shot. People often use Ovidril. As our egg supply gets lower, some individuals start recruit their egg of the month sooner and sooner, and our brain is kind of supercharged trying to get the ovary to do its job and may trigger ovulation at a smaller size. But as long as we're kind of in that 16 to 25 range, I'm expecting I'm getting a mature or usable egg that's potentially capable of being fertilized by sperm. How important is sperm morphology? I would say that morphology can be helpful with fertility. There's a situation called globozoospermia, which is an abnormality where all the sperm look like big balloon heads. And that is definitely indicative of a severe male factor infertility. With that, it's something that even IVF can be challenging with. If we're talking about other fertility aspects, then we think about, yes, morphology tells me about functionality. It doesn't tell me everything. And so morphology is generally a percent. And so if you have 10% of a low number versus 5% of a high number, then that can be still the same number of normal shaped sperm. But there are some abnormalities that are more concerning. The caveat with morphology is it's often a very subjective measurement from lab to lab. So you want to make sure that there's a skilled andrologist, which means kind of a sperm expert, looking at this and giving you a good assessment, and then meeting with your doctor to have a discussion about how impactful this may or may not be. I do have concerns when people get the automated semen analyses. These kind of are less precise than maybe a well-trained andrologist would be. Aside from Clomid, what can help you get pregnant with twins with an IUI? So Clomid, letrozole, or injectable medications that include FSH are aimed to help you get more than one egg released per month to try to achieve the right sperm and egg combination. That said, as a reproductive endocrinologist, my goal has never been, nor will it ever be, twins because of the risks for all involved. And additionally, insurance does not allow me to intentionally create twins because of those risks. It is a quote unquote side effect. It is a potential risk. Triplets or quads are a very high risk pregnancy. Those we definitely struggle to avoid any way we can. Twins do have higher rates of things like preterm delivery. On average, they deliver a month early. They have a higher rate of miscarriage, higher rate of high blood pressure of pregnancy, cesarean section, bleeding after delivery, postpartum complications, separation of mom and kiddos afterwards. And then there's long-term implications such as lower college attendance, higher rates of behavioral disturbances, actually higher rates of child abuse and divorce in families of twins, which is why not just obstetrically and fetal wise, we want to ideally aim for a singleton pregnancy, but long-term for the whole family unit, we want to do so. Uterine polyps. What is a uterine polyp? A uterine polyp is I kind of like to describe it as a skin tag on the lining of the uterus. Those that are greater than a centimeter can act like a natural IUD and impair embryo implantation. Generally less than a centimeter, less impactful, but if you have multiple of them, that definitely can be impactful. We remove them with that procedure I mentioned previously. It's called a hysteroscopy. We place a small camera through the cervix into the uterus and then trim them out or snip them at their base to remove them to optimize the chance of that embryo sticking. Can you ovulate normally from one ovary and not the other? Yes, some people have what we call a dominant ovary, one that ovulates more frequently than the other one. So our kind of textbook assumption is you go left, right, left, right, left, right. For this, we look at kind of the ultrasound and that gives us an idea, but you have some people that'll ovulate only from their left ovary, or ovulate right, right, left, right, left, right. And so I can't accurately predict which ovary you're going to ovulate from next month unless I'm doing an ultrasound and telling you where you're ovulating from. Let's see, Fimbrioplasty surgery before IVF. With IVF, we're actually completely bypassing the fallopian tubes. So if the tube is blocked and abnormal and swollen and becomes what we call a hydrosalpinx or a swollen fallopian tube, then that fluid can follow the pathway of least resistance and flow back into the uterus and basically be like a stagnant pond of water where it's releasing cytokines and enzymes and chemicals that impair the embryo's chance of sticking, and it can actually reduce your chance of success by up to 50%. So if you do have a hydrosalpinx rather than fimbrioplasty, usually we're talking about a salpingectomy and removing the fallopian tube or clipping the tube close to the uterus to prevent that fluid from going back in. Now, fimbrioplasty is generally meant where you try and open the fallopian tube and drain fluid out. But if you're doing IVF, you're already planning to bypass that tube. That tube is not helping you and it could scar and re-swell up. So I generally don't think of fimbrioplasty as kind of my tubal surgery if I'm doing IVF. I'm either removing the tube or clipping the tube. Let's see. Patients with PCOS, thyroid issues, and higher BMI, can you have success with IUI IVF? So tips I would think of, you're going to optimize your general health. We know that reducing your BMI can help with ovulation. Reducing your BMI can also reduce risk of things like miscarriage if it's very high. PCOS, if you have insulin resistance, you should have that treated with something like metformin. Your thyroid should be optimized. We talked about kind of the goal, less than 2.5 if you have thyroid antibodies, and have it monitored closely. And then really we just need to get you to ovulate. The central tenet of PCOS is that people don't ovulate. And so we need to help them release the egg, or they're not going to be able to achieve pregnancy. I've run a little bit over time, but thankfully I have a busy afternoon of taking great care of patients. And so I unfortunately do have to run. But I'm happy to answer questions. I'm sure I'll do another Facebook Live event. Stay tuned. If you want to meet with me personally, you can meet with me at Reproductive Care Center. My partner, Dr. Blauer, is available. We're committed to trying to get you in very quickly. We actually have a fast track program to get you in the door and get you through your diagnostic testing as quickly as possible and hopefully directly into treatment. Usually it's up to a month of testing, and then the next month we can get you into whatever treatment is available. But thank you to each of you for your excellent questions. Thank you for tuning in. And I wish you the most success in your family building journey, just sending love and light to each of you. Thank you again. Take care.